I am Dr. Mrithyunjaya Kalmath, lead consultant cardiovascular surgery, minimal invasive and heart transplant surgeon at Apollo Hospital Navi Mumbai. So today I was in Heart Failure Association of India 2025 conference. I was here to talk on nuances of heart transplantation in failed fontans. Fontan surgery has been there for more than half a century now, and as we all know, Fontan is a palliative procedure. It's bound to fail. Even Francis Fontan said that it's bound to fail. So, over the last 2 to 3 decades, the outcomes of Fontan have improved. So, Fontan survivors have increased. The number of people living with Fontan has increased. Even the HLHS palliation has also improved. That has led to increased number of Fontan patients living. So these patients someday in their third or fourth decade are going to fail, and the failure for Fontan is either ventricular failure or failure of the Fontan pathway. So it's going to be a major burden of failed Fontans. Either they die of no treatment or they will require a transplantation. Almost more than 10% of the transplants failed, and among them only 2.5% get a transplant as per Australian data. Indian data is even more dismal. So we will have significant number of Fontans coming to us with failing Fontan. So, and these patients require transplantation. And the major problem with them is if they are not referred for transplant in time, they end up having renal and liver dysfunction called as FALD, Fontan associated liver disease, protein losing enteropathy, and plastic bronchitis. These, when they develop, they force us to go for a multi-organ transplantation, which is associated with the poor outcomes. So the whole emphasis of my talk is to realize the upcoming pandemic and to be able to identify and treat them in time. We'll be able to give them another 1 or 2 decades of good quality of life. So Fontan patients generally are congenital heart diseases and they have some abnormalities, and when you go for a transplantation, there are issues of anatomical variations in their connections, and you need to plan well accordingly and prepare the connections prior to clamping the donor, because you will be running out of your ischemic times if you don't plan it well. And we went on to the different preparations that you need to make for situs inversus, dextrocardias, abnormal pulmonary and systemic venous connections, so all that stuff. So the emphasis is on identifying them early and referring them for surgery in time, and planning and executing your surgery well, and harvesting adequate donor conduits to tailor to the patient's anatomical requirements.